Welcome to the critical thinking and nursing process of the high-risk intrapartum client and family. Okay, so we don't see this recording. Okay. Trying to move my slides. We're going to start off with episiotomies. And as you can see, we're going to cover midline and mediolateral episiotomies. These are not routinely done anymore, only when there's extensive vaginal tearing. Then, of course, if we need a little bit more room, we could do a mediolateral episiotomy. If the baby has an abnormal position, if it's a large fetal macrosomic baby, or if we just needs to be delivered quickly, then we can do an episiotomy. Your midline, that's where our first slide comes in. Our midline episiotomy is less blood loss, it's less painful, it heals quickly, but a big disadvantage is it may extend to the anus. And then our mediolateral advantages are it's more room. The big disadvantages is it's more painful, it's a bigger space, it's about 3 to 5 centimeter cut. It's more blood loss, and it does take a little longer to heal. And these are the moms that when we were talking about normal postpartum, we want to make sure that we give them their witch hazel, which is their little tucks. Okay, it's the round wipe that we said that it's tucks that has the witch hazel, and then epifoam or dermaplast because it has a little bit of lidocaine to soothe the area. Okay, and moms will do this every 3 hours when they change their perineal pad, when they change their tucks, they do their perineal dermaplast or epifoam, and then they can change again. So they'll do the perineal care every 3 hours, and these are the moms that you will see that will need their epifoam or their dermaplast and their tucks as well. Give them some relief from their bottoms. Precipitate labor. So this is a labor that is completed in less than 3 hours from start to finish. More common with, of course, multips, so G2s and on. Okay, they've already had a baby, so these are multi-para moms. Women risk of trauma to the fetus as well as trauma to the maternal soft tissue. Management, early prep, and support the perineum. We have precipitous delivery trays if they come to the hospital and they're go to triage, and of course they are already 5, 6, 7 centimeters, and they just left their house an hour ago when they thought they were maybe in a stage 1, maybe phase 1, where they were only like 2, 3 centimeters, and all of a sudden they're already like at 6 or 7. Everything has happened very quickly from when they start to labor to when the baby is born. So we can grab a precipitous delivery tray, which has hemostat, scissors, and a cord clamp. Okay, now you can think of this very quickly, and we're not able to labor with mom. The risk for the mom is cervical lacerations, vaginal lacerations, and even rectal lacerations. This baby's coming out very quickly, okay, and we're not able to prep that cervix. Some risk to the neonate is obviously hypoxia. Okay, it's caused by the uteroplacental insufficiency resulting from these hypertonic uterus. Okay, the uterus is not leaving. Remember those contractions, right? Increment, acme, decrement, and then they have that time where it's the time of reoxygenation, then the next contraction starts. Well, in between that, you have to have this period of reoxygenation. These contractions are happening, and this is what we call hypertonic contractions. There's no resting phase, so this is why there's a big risk for baby for hypoxia. Some nursing considerations with precipitate labor is you don't want to leave this patient alone, especially if she comes in and she's already 7. Okay, So if she brings the support with her, they're in the room, and then they're your eyes and your ears as well. And if they come by themselves, and you're the labor nurse taking care of this patient, you will stay with the mom. Okay. Make sure that you have sterile gloves near. If she's ready to tell you that she feels like pushing, you want to make sure you instruct her to pant, okay, to just do some blows to decrease the urge to push. So, okay, let her pant, let her blow, okay, to decrease that urge to push. Buy yourself a little bit of time, okay, to get a healthcare provider in the room so they can come and deliver her. Support her perineum. Okay, if crowning, when you put her up in the stirrups and you bring her from triage to the room and you check her again and baby's crowning, make sure you support that perineum with a sterile towel. Okay, all labor nurses are trained to deliver a baby if they have to. Okay, and just before oxygenation for that baby, maintain her side laying position to give her the optimal to optimize this uteroplacental perfusion, okay, fetal oxygenation to that baby, okay. Then we are going to continue on with perineal lacerations, okay. The definitions are exactly what's happening with the perineal lacerations. First degree, your second degree, your third degree involves the anal sphincter, and your fourth degree is a third degree but goes through the rectal mucosa. There is a picture of a perineal laceration. And again, these are for sample use only. They're copyrighted. It's for sample use. Since am I recording the lecture, I want to make sure that I show you visuals as I am recording these lectures, but this is what I usually show in the classroom. It is only for sample use for the use of this lecture. Okay, just want to make sure that I highlight that. I know the company wants us to highlight that. But here again, you could see the fourth degree episiotomy, the tear in the perineum, okay, into the rectum, including the anal sphincter. Okay, and of course your repair from inside out. Now this is painful, so what do we do for nursing considerations? Lots of ice, natural anti-inflammatory, lots of ice, analgesics. This is also the mom that you will be giving the epifoam or the dermoplast to put in her bottom, because this has a little bit of lidocaine, and since she has stitches for her bottom, has a little bit of lidocaine and will soothe her bottom. So this is the mom that also requires the epifoam, the dermoplast, and also the Tux, which is the witch hazel. Okay. Moving on to more high risk, some challenges during intrapartum are perineal hematomas. Okay. It's a collection of blood in the subcutaneous layer of the perineal tissue, and it's characterized by this purplish discolored area. There can be swelling, there can be feeling of pressure. This is severe pain in the perineal area. It's feeling of pressure between the legs. We do have a picture that shows perineal hematoma. Okay, the more red that it looks, probably has a little blood clot in there, and that probably has to be incisioned and drained. Okay, if they're clear, okay, if the hematoma is actually clear, then it usually heals on its own in a couple of days. But this one will give mom a more of a pounding sensation in her bottom, lots of pain, and most likely this will have to get drained. Okay, now this usually happens if there's been a challenging delivery that was a little bit complicated, and maybe we had to use a vacuum extraction to pull the baby out. You have to make sure that you put that vacuum on the baby's head. And if you just got a little portion of that labia, then that caused enough pressure to cause a perineal hematoma. You should never see them, but if you do, that's probably why. It's because adrenaline was kicking. Everybody was having one mission: get this baby out and get this baby out alive, pink. And when they did put in maybe the tones, maybe you were dropping tones, the heart rate was low, and when you were putting in, the healthcare provider was putting in the vacuum extraction, there was maybe a little piece of labia that was there. Now, interventions, obviously we're going to get vital signs, monitor for abnormal pain, okay? So this is probably going to be from forceps, from a vacuum delivery that this mom had from this difficult delivery, ice, analgesics, okay? We want to monitor her eyes and nose because there's so much pressure in her bottom and she's hurting so much that a lot of times she's unable to void because there's so much pain. That we want to make sure that we can straight catheter. Okay, if she's unable to void, she's going to be on antibiotics. And if it's the color, if it's that dark, like this picture, this dark red in color, then you prepare for an incision and evacuation of the hematoma. Then we have more challenges with high-risk intrapartum, and that's malposition babies. Okay. Of a persistent occiput posterior baby. Okay, what is a persistent occiput posterior baby? This is a picture, okay, of an occiput posterior baby. See, the back is to mama's back, okay, and you see why 97 to 98% are head first, they're vertex, right? 97 to 98%. So this causes extreme back pain, okay, severe back pain. I'll give you the definition of a persistent occiput posterior baby, and this is when a posteriorly presenting head does not fit the cervix as snugly as one in an anterior position. So what does it cause? It causes severe back pain, increased use of forceps and vacuum to get this baby out, increased risk of lacerations, and then our nursing plan is going to be to position mom knee chest. Okay, the hips are going to be higher than her head, and that aids in fetal rotation. Sometimes a back rub will help. Bladder, empty her bladder every 2 hours to make sure that that bladder is going to be empty so that baby can come down. Sometimes the fetal heart rate is best heard on the lateral sides of the abdomen. Okay, so this is for malposition. And then pictures so that you know what the forceps. We don't see forceps pretty much anymore used unless they're the king of forceps and they've been doing practice for a very long time and they really know how to use a forceps. We really don't see forceps anymore. What we are seeing more are vacuum extractions. Okay, if need be, and we are seeing more of the vacuum extractions. Okay, but you see it has to be completely, you can't get any little piece. That baby is crowning and that baby's head is really below. We cannot get any piece of that labia. Or mama will have a hematoma. And then this is obviously knee chest. If she is not having an epidural, if she did not have an epidural, we can do knee chest like this. If not, she will be laying in bed and we will put her knees closest to her chest, but she will be laying in bed. Okay, her back is to the bed. And I will show you that in a little bit. Okay, malpresentation. Also, we have malpresentation can pose a high risk to intrapartum as mama is in the labor room. Is a breech presentation. We saw the breech presentations. It's a face, it's a brow. Okay, a shoulder, a transverse, or no vaginal delivery, transverse baby, malpresentation. Okay, a shoulder. So the treatment again. Okay, the treatment will be a manual rotation, so 2 hands, 10 fingers, and we can get the outline of the baby and just try to move the baby in utero, okay? Outside, the hands are outside on her belly. We're trying to move, and that's an external version of what we're doing. But then, of course, that poses risk because, again, it has placenta, you have umbilical cord, baby's in utero, and you don't want to make sure that the baby's still fetal well-being. That is done by a healthcare provider, and then you have the ultrasound tech and you have a labor nurse all there. We can still do that, or the patient will go for a C-section. Okay, it depends on healthcare provider. on the team of healthcare providers in the hospital where mom delivers at. More visuals for him. This is Adam, so you've got more visuals here as you're studying. The book also has great visuals for you as well. And then you have more fetal position. Okay, so fetus in the posterior position. So this is left occiput because it's coconut and posterior because the baby's back is kind of getting closer to mama's back. And then you have the left, and then you have the occiput, and you have the transverse. That spine is right to baby spine. You have something what we call macrosomia. We talked about gestational diabetes last, and we talked about these big juicy babies, and they tend to be big, okay? You tend to grow in utero a little bit more, get a little bit more chunkier and bigger. Not necessarily are the lungs growing, so you might have a baby that's 37 weeks, but also already weighs about 9 pounds. That's a macrosomic baby. That's not your average baby, the weight for an average baby. Then you have a shoulder dystocia. We have a picture, and that's when the fetal head is born. Okay, but what happens? Your shoulders are too broad to enter and deliver through that pelvic outlet. Okay, because remember the head, and then we have to dislodge the shoulders. Okay, this is an emergency, so they may experience a fracture of the clavicle or the humerus, and they might experience also asphyxia. Okay, so this is why prenatal care is so important in the care of mom throughout her pregnancy, because if we know and she develops gestational diabetes, we're watching, we're gonna make sure that that baby is not going to be 9 or 10 pounds for her to deliver. Okay, we're going to take her earlier, and depending on her sugar levels, we're going to go ahead and take her early so that she could deliver this baby, or this baby will get delivered by C-section. But we will not try and deliver and risk a shoulder dystocia on this mom. Okay, if this is an 11-pound, 10-pound baby already. So that's why your ultrasounds are very important, so that we know the weight, you know how big this baby's going to be, and if this mom has size to deliver this baby as well. And then there's nursing responsibility. So we've got Mac Roberts, because if this is in the labor room, then, and this is happening, and the baby is out, and we need to get this baby fully out, we can put mom on Mac Roberts maneuver. Okay, and this is also your knee chest we were talking about. Mom is laying in her back. Of course, this is a great picture. She's holding her own legs, but in the delivery room, we're holding them for her, and we're putting them, her knees to her chest as well. We can do it this way if obviously she has an epidural, and we can do something called Mac Roberts maneuver. What we're trying to do is dislodge the shoulder. So what we're trying to do is move her pelvic bone. Okay, move her pelvic bone. So if this is the way she's down, the minute that she raises her legs, we can move her pelvic bone and dislodge, okay, those shoulders. So I'll give you the definition of Mac Roberts maneuver. Women's legs are flexed apart with her knees on her abdomen. The sacrum straightens. The symphysis pubis rotates towards mom. This is what's happening. The symphysis pubis rotates towards mom, and the angle of the pelvic inclination is decreased, and then by doing that, it frees the shoulder. So you're able to dislodge the shoulder and bring the anterior and posterior shoulders delivered. Okay, so back to, I want to make sure I don't miss anything here. So Mac Roberts maneuver, or prep for a C-section, and yes, we're going to check the infant's shoulders after delivery. Okay, sometimes they're just bruised and they're just guarding their shoulder, and you want to make sure, we got an x-ray because you want to make sure that it's not a fractured clavicle or humerus. And then we're going to cover C-sections and reasons for C-sections. And in your book, on page 636, you have a great C-section birth that you could see, starting from the epidural placement, okay, and all the way to the birth of the baby. So page 636 in your book, it is chapter 24. Really like this book. It's got great resources for the students. Okay, again, this is a sample use only copyright picture, but you could see an incision, a low transverse incision, okay, and then of course the baby's out for delivery. Getting out to get delivered. Okay, sometimes the slides get stubborn and they don't want to move forward. It's thinking. Okay, let's go. Thank you. So C-section birth, cesarean birth reasons, a malpresentation, okay, placenta previa or abruptio, a fetal distress, okay, anytime the baby is showing you that it is a not reassuring fetal heart tones, okay. Heart rate is above 160, the heart rate is below 110. Decels, all of that is fetal distress. Failure to progress, baby is stuck. Say that's the mom that's 6 centimeters, 7 centimeters, now in active phase of labor, but the baby has been stuck for like 4 hours and not moving. Okay, well, we have something for failure to progress in the hospital settings, and maybe some of your instructors have told you about it. It is called a peanut ball, and we put it in between their legs and we move them completely to their side, to their left side or to their right side to stretch out the pelvis so that that baby can descend down. But sometimes it is a true failure to progress and the baby will not descend down. And then if there's a prior uterine scar. And then we have a delivery here as well too. Okay, this is from another book as well. We'll just stay right there for a minute so that we could finish the types of incisions. Could be classical or vertical, could be a low transverse incision, and of course nursing responsibilities for C-sections. You still want to, with the Foley, with the pre-op medications, we give meds. We still, some hospitals will give Bicitra, B as in boy, I-C-I-T-R-A. And we do give some pre-op meds, and those are usually the anti-acidic meds, okay, to calm the acid in the stomach so that when we lay moms flat for C-section, they don't throw up and they don't get nauseous, okay? And then also remember the pre-op and post-op teaching for C-sections, okay? And those are vital signs. You still have to assess your fundus, even though it's a C-section. You still have to gently assess the fundus for vaginal bleeding. There's an abdominal dressing, so you have to assess the stitches. Mom is going to have a Foley cath, remember, which is usually going to be taken out at 12 hours post-delivery. Intake and output, and again, because it's a C-section and it's surgery, turning, coughing, and deep breathing, okay, afterwards. A little bit more on high risk is a cord prolapse. I think also there are cord prolapses in one of your virtual sims for OB Clinical as well. So cord prolapse. So what happens with a cord prolapse? I have a picture to show you. Sometimes these slides get a little stubborn. There we go. Okay. So these are some pictures to show you with the cord prolapse. Okay, and you have the definition. Again, these are copyrighted for sample use only during lecture. Occurs when the loop of the umbilical cord gets in front of the presenting part. That's the loop. Okay. Another good picture that we have here is how the umbilical cord can just slide first. And then, of course, it could cause a cord prolapse. Another picture is here. Another sample use copyright picture is here. These are the amniotic fluid. These are your bag of waters. And a lot of times, see where this cord is at prior to breaking the waters. And if either mama ruptured or if they were artificially ruptured for her, what happens with the pressure and then the leaking, the cord comes out first. Okay. So this can happen as well. So we want to avoid cord compression, and we want to put mom in Trendelenburg. This is another one of the emergencies that if this is the case, we could put mom on Trendelenburg. If this is a cord, we will sit on the bed. We will put pressure on, and I have another picture to relieve the compression of the prolapsed umbilical cord. We could put sterile gloves on, do it like a sterile vaginal exam, but we're putting pressure on that baby's head to remove the pressure, the compression of that cord. We're on the bed, we've got covers over us, and we are wheeling mom to the OR for a C-section. If that's what we have to do, then that's what we will do. We can put her on a knee chest position if she doesn't have epidurals. Of course, she can be with her tush up in the air, her knees on the bed, her elbows on her bed, and she could do knee chest, and that's great. But if she has epidurals already, then we have to put her on Trendelenburg and sit on the bed and put some pressure on that baby's head, and then we're wheeling her to the OR. Causes for a prolapse cord, why this is happening. So some causes could be premature rupture of membranes, could be placenta previa, could be some tumors, could be cephalopelvic disproportion, or just a small baby. And then the cord is maybe longer and it's just a small baby in utero. And how do we manage? We always want to make sure that there's fetal heart tones, okay, in this baby, 110 to 160. On the monitor, we're going to see variable D cells. Okay, so if we see variable D cells, we're going to start doing some interventions. Okay, we're going to give mom 10 liters of O2 via a non-rebreather mask. If this happens in the middle of a delivery and the cord, the head is out and all of a sudden there's this little slide of cord, it's not unusual to continue with a very rapid vaginal delivery, or in a sterile vaginal exam, if you feel that cord, you are going to push up the presenting part, like I said, hop on the bed and go to C-section. And again, immediately, because we're going to see variables. Sometimes the variables give it away. We know that something's going on with the cord because it's umbilical cord compression, right? The UVWs on the heart rate. So if that's the case, we put moms on 10 liters of a non-rebreather mask, and we're constantly rotating mom left, right, to put pressure off the cord. We also talked about an amnio infusion if that's the case. But the cord prolapse is you're actually seeing the cord coming out of the vaginal area, okay? The vaginal entrance. You actually can see the cord. So you're going to prepare mom for a C-section if this is the case, emergency C-section. Okay, and then the symptoms that we saw here is a fetal cord felt on a sterile vaginal exam. Sometimes that's the case, and we just want to push up the presenting part. And then, of course, fetal heart rate, the variable D cells, okay, on that external monitor. So we went through some of these pictures. And again, we can put mom on knee chest if she doesn't have an epidural, okay, and you could see. She's laying there, she doesn't have an epidural, we'll put a sheet over her and she's off to the OR. If not, then we have to go ahead and put her in Trendelenburg, go on the bed, make sure that we do the sterile vaginal exam, and we're pushing that baby's head with our fingers, pushing against, pushing up to the presenting part, and we're wheeling her to the OR. Then we've got some terminology again. Dysfunctional labor can lead to a high-risk labor and delivery process here. Dysfunctional labor, you can have hypertonic contractions, so it's hypertonia, or you can have hypotonia, okay? Hypotonic contractions. Hypertonia is painful contractions, and they're seen in early labor. And that is, again, we were talking before with the hypertonic contractions and the precipitous labor. It's pain due to uterine muscle cell anoxia. So there's no normal resting phase. Okay. In hypertonia, what we do is we'll give analgesics, we'll give hydration, lateral position, and again, because it's lack of oxygenation, we want to make sure we give 10 liters of O2 via a non-rebreather mask. In hypotonia, which is sometimes seen in active labor, sometimes epidurals will give to mom. She's no longer in pain. It took the edge off, but what happens is relax to the point where we see hypotonic contractions. They're not coming as they want to. They're slow. They're not causing the labor. They're not causing a true labor that the contractions are consistent. So everything slows down. So they become hypotonic. Okay, the labor becomes hypotonic. Or caused by overstretching of the uterus or malposition. These are hypotonic contractions are ineffective contractions that are unable to dilate the cervix. Okay, now in hypertonia, what do? We give Pitocin because we want uniformed contractions that cause no harm to baby, but uniform contractions. And we do an ultrasound to rule out a malposition. And sometimes in hypotonia, we're giving Pitocin. Sometimes these are labors that we have to use vacuum-assisted birth, or moms end up in a C-section. Now, I always like to think about some risk factors for like dysfunctional labor. Sometimes the risk factors for dysfunctional labor is advanced maternal age, so over 40, some fetal macrosomia, so big babies. Depending on the fetal presentation, that they have a dysfunctional labor, and then a lot of times multi-fetal pregnancies, so babies, more than one baby in utero, sometimes you will see. But a lot of times if it's more than one baby in utero, right, what's going to happen? They're going to have a C-section, whether it's twins or triplets or quads. But we do see dysfunctional labor. We tend to see dysfunctional labor, obviously, as well in multi-fetal pregnancies. But we're not going to deliver those vaginal. Some key points: dysfunctional labor occurs as a result of hypertonic uterine dysfunction and hypotonic uterine dysfunction. Functional relations among uterine contractions, fetus, and mother's pelvis, all altered by maternal positioning. That's why we put on her left, we put on her right, we put on her right, we put on her left. We could be there all shift, all through the delivery. Another high risk intrapartum challenge is uterine rupture. This is a serious OB injury. It occurs in 1 in like 15 to 2,000 births. It may be a result of a VBAC, vaginal birth after a C-section. It could be trauma, it could be excess Pitocin. Okay, so there's an excess of uterine contractions. And the fetal lie occurs more with multi-gravida moms. So moms have already had more than one, a G2, okay, more than one pregnancy. G2, P2, so 2 deliveries, 2 pregnancies. Symptoms: it is excruciating pain. There's a tearing sensation. It's sudden, it's sharp, decreased abdominal pain. Okay, it's lower bottom abdominal pain. Contractions stop, so the cessation of contractions. Drastic decrease in fetal heart tones. And I always like to show the pictures because it makes a whole lot more sense when we're talking about a uterus that ruptures. That is going to be a tearing sensation. That is going to be sudden, sharp, lots of pain, a drastic decrease in fetal heart tones. Okay. Usually babies will go Brady. Then you'll see that late decel. Then all of a sudden they go tachy. And then there's absent variability. So they're trying to compensate in utero to the point where they're like, help me, I can't do this anymore. Okay, and these, again, this is another sample copyrighted picture, but it's a great picture for teaching purposes because it shows a lot of times from a previous C-section scar, and then all of a sudden the tear. And then of course, the placenta is not doing anything else to baby because of the uterus, right? The placenta is attached to the uterus. And if it's not, now there's a problem with the uterus, nothing's happening with the placenta. Okay. Another one, condition before, so there was already, okay, a scar, and then of course a separating scar during labor, and then all of a sudden there's that uterine rupture. Okay. And then of course in this picture, it's a great picture because it's bleeding, pain, and you've got to get that baby out because then that lack of oxygenation. And that's where that baby drops the heart rate, and that's where the baby gets the late T cells because it's happening in utero. Yes, of course, the placenta, we're giving nothing to the placenta now because placenta is attached to the uterus, to the uterine, to the endometrium of the uterus. Before we go to our next topic, just want to go through the slides. Excruciating pain, symptoms, drastic decrease in fetal heart tones, emergency C-section. Absolutely. And then causes, we talked about some of the causes from separation of a scar, intensive uterine contractions, overstimulation with Pitocin, difficult forceps-assisted birth. Sometimes the blood loss could be concealed. Sometimes there's signs of shock. And sometimes the fetal parts are easily palpated through the abdominal wall. So that could also happen as well too. How we manage is we could do a complete uterine rupture. Then there's an extension through the entire uterine wall. So we have to manage the shock, replace the blood loss, and maybe there is a possible hysterectomy because we can't save that uterus. But if it's an incomplete uterine rupture, small little tiny tear, didn't absolutely complete tear, we could do a laparotomy, we could repair the tear, and we could do just blood replacement. Okay, so amniotic fluid embolism. I know this question came up in one of our WebExes, and it's absolutely doesn't happen often, absolutely not. Amniotic fluid embolism is rare with capital R-A-R-E, rare, extremely dangerous OB complication. Okay, usually associated with the induction of labor. It is now said to be, the term actually changed a bit, and it's now saying to be an anaphylactide, anaphylaxis response to amniotic fluid in the maternal circulation. The clinical picture is dramatic, okay? We don't want amniotic fluid in the maternal circulation. We absolutely do not. What is happening here usually occurs during labor, okay? Just like it tells you, just like the definition says, occurs when amniotic fluid is forced into, there's an opening in that maternal uterine blood sinus, there's an opening. After membranes rupture, okay, goes into the circulation, or partial premature separation of the placenta, okay? Amniotic fluid is forced in there, okay, where it's not supposed to, where it's just, you rupture and everything is down and out. It went into the circulation, and of course it's going to cause pulmonary artery constriction. So it usually happens during labor if it's going to happen. Remember, it's rare. It's about 1 in 20 to 30,000 cases. So it is rare, but it is extremely dangerous. Most patients do die within an hour of the onset, and there's no definitive diagnostic test that exists. Okay, normally what will happen with these patients is they sit up, they have a sharp chest pain, they've got this inability to breathe because of the pulmonary artery constriction that occurs. They go pale, they go gray. That's because the pulmonary emboli and lack of blood flow to those lungs. Okay, and then of course within minutes, usually the patient is unconscious, and there's a danger. There's a fetus danger. It's placed. Okay, now on this fetus because of no oxygenation to the placenta. Okay, the placenta circulation halts. So extremely dangerous OB complication. That's why I put the symptoms there for you, gave you a little scenario and put the symptoms there for you. Respiratory distress, shortness of breath, cyanosis, they start getting this sharp pain and inability to breathe, the chest pain. They do get hypotensive. Okay, this is where they've got the chest pain. They sit up, they grasp their chest, they can't breathe. They get tachycardic. They've got acute hemorrhage. So what is happening with amniotic fluid embolism, there is severe hypoxia, of course, because you've got that pulmonary artery constriction that's occurring. You've got that pulmonary emboli. Got severe hypoxia and hypotension. So usually if the patient doesn't die from that initial respiratory insult that she needs to overcome, then there is severe hemorrhaging and coagulation that happens. So our goal of treatment in her management, okay, our goal of treatment is oxygenation, maintaining cardiac output and blood pressure, and correcting that coagulation that's happening. Okay, these are patients that end up in the ICU. Sometimes the babies don't make it. So what is the prognosis? Depends on the size of the embolism and the speed in which the emergency was detected and the speed of that emergency and those interventions. Okay, for good prognosis with these infants and moms. So management, oxygen by 10 liters of a non-rebreather mask. CPR is done within minutes. Okay, she's going to need CPR within minutes. Also, CPR may be ineffective because of not relieving that pulmonary constriction. So blood is not circulating to the lungs, and then death may occur. We prepare to intubate her and do an emergency C-section delivery. Sometimes we are still trying to, because we want to resuscitate and stabilize mom first, we're trying to stabilize mom and the baby has already died in utero. And we're doing a post-mortem delivery to deliver this baby that didn't make it and it's dead. Death, just like I have it there, death may be imminent if not caught on time. And then with all the management, I want you to write also the IV. Obviously, she's going to have a 16 to 18 gauge IV. And before we take her back to her C-section, obviously, we could put her on her left side for more oxygenation, obviously. She's got her oxygen, she's got her 10 liters. So this is a rare, extremely dangerous OB complication, but it's more of an anaphylactic response to amniotic fluid. So it's not supposed to happen, which good thing is rare. Sometimes you practice for 20, 30 years and you see one or you see two. Rare, but extremely complicated. And then, of course, these patients are treated in the ICU. The stats are that, yes, they get a sudden cardiac arrest in pregnancy. Like I said, 1 in 20,000, 30,000 pregnancies. Okay. Neonatal survival, time between the arrest and the delivery. And then, of course, we have to treat her hypotension. And then, of course, meds, obviously. Okay. Treat her coagulation. If we're going to treat her hypotension, we're going to give her pressors as necessary. We're going to treat her coagulation with fibrinogen, with a platelet transfusion if she's less than 20,000, and then give her meds to maintain that blood pressure. Okay. The first med that should come to mind with the pressors are dopamine. And then, of course, we want to improve contractility, so we have to give her digoxin. Okay, and then steroids. Okay, so hydrocortisone. and then uterotonics as well, okay, because of the postpartum bleeding. So Pitocin, Hemabate, Metrogen, okay, Cytotec. So that is for your information, but it's just a picture of this patient once she gets into the ICU, how dangerous this could be. And a good thing that this is very rare. You might never see it, or you might if you practice, for a very, very long time. We might see one or two, maybe. And DIC. What is the definition of DIC? Overstimulation of the coagulation process triggered by underlying disease and vascular injury. So how we treat DIC is by treating the underlying cause. Okay. A picture of DIC and what is happening, the red blood cells, the clotting agents, okay, throughout the body, supply of the clotting agent. Then, of course, during pregnancy, coagulation can be initiated spontaneously, and then, of course, there's the hemorrhaging. Blood escapes through the ruptured wall. Okay, you have an insufficient clotting agent are available to control the bleeding, so that you have the hemorrhaging. Okay, and then you have causes. Now, how we diagnose DIC is based on clinical findings. So bleeding might be occurring from gums, from the nose, from the IV site, from the uterus, from the episiotomy. Postpartum, she might have a distended uterus. Okay, she might have petechiae. Okay, so the diagnosis is based on clinical findings and lab markers as well. Okay, when I talk about lab markers, I'm talking about decrease in platelets. So 50,000. Okay, where your norm is 150,000 to 400,000. We're talking about low platelets of 50,000. We're talking about low fibrinogen of 100, where the norm is between 300 and 600, and low prothrombin time. Okay, so based on clinical findings and lab markers for the DIC. Now, causes of DIC, abruptio placenta, amniotic fluid embolism. Remember, we said that management is to treat the underlying cause. We have to treat the cause of what's causing DIC. Okay, so abruptio placenta causes amniotic fluid embolism, a dead fetus syndrome. So the fetus dies, but it's retained in utero, sometimes for at least 6 weeks. And that's a dead fetus syndrome. Severe preeclampsia, of course, septicemia, and hemorrhaging. And then our management, okay, gave you a little bit prior, but our management, yes, again, we're possibly transferring this mom to the OR, to the ICU. Assess for vaginal bleeding, observe for her clots, side lane position, again, have an IV of 16 to 18 gauge, oxygen, possible intubation, DIC because now she can't clot, press her meds to maintain her blood pressure, so maybe dopamine, strict I's and O's. We have to check her renal function, and antibiotics. We have to give her antibiotics. Okay, so her treatment, before we go into key points, her treatment would be her blood components. We're going to probably, because of severe hemorrhaging, have to give her factor 7. And sometimes to control that blood loss, we have to do bilateral uterine artery embolization, okay, to control that blood loss. Okay. So her causes, her management, and her symptoms, signs and symptoms. I don't know if I told you before, but her signs and symptoms, she'll show signs of being, obviously because she's bleeding out, she'll be tachy, she'll be hypotensive, and she'll be diaphoresis. So if you want to make a note on that, she'll be tachy, hypotensive, and diaphoretic. Okay. And then our next high risk, last but not least, we have some key points, and then we'll have to cover HELP. So OB emergencies occur rarely but require immediate intervention to preserve the health or life of the mom and the newborn, the fetus or the newborn. So these OB emergencies are shoulder dystocia, prolapsed cord, rupture of the umbilical of the uterus, and amniotic fluid embolism. Clotting disorders are associated with many OB complications. We just talked about DIC, which she bleeds and doesn't clot. Okay, so we've got to give her blood components, we've got to give her factor 7, or we've got to do that bilateral uterine artery embolization. And then again, management of late pregnancy bleeding requires immediate evaluation. Its care is based on, yes, gestational age, the amount of the bleeding, and the fetal condition. And then that leads us to HELP. And HELP syndrome is characterized by the true pathology of HELP still remains a mystery, I have to say that, and the cause is currently unknown. But what they do, latest research of what they have found is that HELP is an extremely severe form of gestational hypertension. It's what they have found. Usually happens between 27 weeks to delivery. Okay, so usually after 27 weeks. Another interesting fact on HELP is that usually accompanies severe preeclampsia, with the primary presentation consistent of hepatic dysfunction. Okay, and we're going to go through what HELP is. Okay, we've got the acronym right there. It's hemolysis that leads to anemia, and that is a decrease in oxygen capacity, and that is red blood cell injury. Okay. You also see with hemolysis increase in LDH. Okay, LDH is lactate dehydrogenase. So increase in LDH. And this increase in LDH, and I'm talking about 600 when the levels are between 100 and 300, this indicates an increase in cell damage. So the enzyme that helps produce energy. Okay, so there's an increase in cell damage. And then we've got elevated liver enzymes, and that leads to your epigastric pain. That's AST high, so AST elevated to 70 when the normal is 8 to 36. And then you have low platelets, so that leads to abnormal bleeding and clotting. And usually they're less than 100,000, so then of course they're in the category of a thrombocytopenia, because they're less than 100,000. Okay, and just on a side note that if we have to do a C-section, we need to do platelet transfusion to maintain that count at least more than 50,000. Okay, if we're going to take mom back for a C-section. So one more thing I wanted to mention with HELP is that we kind of went through the symptoms, and one more thing I wanted to add, because we did hemolysis, which leads to anemia. We did elevated liver enzymes, which leads to epigastric pain. We said low platelets leads to abnormal bleeding and clotting. I also wanted to mention some of the symptoms with HELP, which is nausea and vomiting. Okay, and then headaches also with changes in vision, and some moms will have diarrhea. So the treatment for HELP, believe it or not, is to deliver this baby. Okay, because remember, this is also, it's a syndrome that's characterized by thrombocytopenia, by hemolytic anemia, by liver dysfunction. We don't really know the true pathology, remains a mystery. The cause of what causes it is currently unknown, but we do know that it usually accompanies severe preeclampsia. So of course, that whole rationale with stabilize mom and get her delivered, the minute that this baby is born, these symptoms are gone. Okay, so the magic to this is deliver this baby. Okay, too much stress. Pregnancy is too much of a stressor to mama's body. And when help happens, they are strictly related to pregnancy and they won't return after this baby delivers. Okay, we just have to get mama better. So treatment, we want to improve that platelet count, close observation, prevent the bruising and the bleeding, and deliver this baby. That is the magic to help, is get this baby delivered. And that concludes our high risk intrapartum lecture. Thank you for listening.